Good morning, everyone. And dear stakeholders, this is your day. And so it's my pleasure to welcome you at our stakeholder forum of the EU-JAMRAI 2. As all you know, we consider that AMR cannot be fully addressed if all stakeholders are not joining us. And so in this regard, this stakeholder forum is critical for the success of the EU-JAMRAI 2. And your expertise and experience in the field of AMR give an outstanding added value in the joint action. And we absolutely need you to contribute to implement the EU recommendation efficiently. So today we will have 3 roundtables with different panelists, and thank you very much to the panelists for accepting our invitation. We appreciate it really, thank you so much. So the READ roundtable will address first human health, then animal health, and environmental health. So I wish you a very productive working day, and to start with the panel on human health, I'm pleased to call Rita Murri from the SGAP. Thank you.
So thank you very much. First of all, to invite me here and have really a great inspiration. First of all, I'm Rita Murri. I'm a so-called end user because I'm an infectious disease specialist working in a very large hospital in Rome, Italy, Gemelli Hospital. So I'm the head of the consultancy unit, so all my work is doing consultancies for infectious disease problem and promoting antimicrobial stewardship and optimal antimicrobial therapy for any infectious problem. So I'm here as an end user, but also I'm the privilege to be part of the executive committee of SGAP, that is the group of ESCMID, probably you know, that is involved in antimicrobial stewardship. So I represent here more than 500 members, perhaps. And I have also the privilege to be part of the WHO antimicrobial stewardship coaching program. I don't know if you know it. That is it was really a very nice experience. So I'm an end user also from an education point of view. And we host in Rome also an advanced module of the antimicrobial stewardship certificate from ESCMID. So another opportunity to meet people and to discuss together how difficult it is to implement tools, guidelines, and also theoretical approach in the real life. So I'm very happy to be here to promote a discussion about, this is really the title of this session, so advancing in human health from paper to practice, ensuring the JAMRAI's impact on the front line of antimicrobial resistance. So the big context is, again, antimicrobial resistance. That is our tremendous problem for which we are here. But now we would like to discuss about how JAMRAI deliverables, products, and also videos and activities can be implemented in the real practice. So JAMRAI staff are really interested in this discussion. And it's very interesting for me also how strong is the approach in One Health vision, because here continuously we talk about animal health, environment health, and human health as a big one, the One Health. So this is very interesting also from my part. So it's my pleasure now to introduce the panelists of this session. I can call them one by one and asking them to introduce themselves and let us understand how their activity in the organization or in the agency they work are linked, are related to the issue that we are now discussing. So how is the link with the JAMRAI goal, especially? So it's my pleasure to call, first of all, Diamantis Plachouras from ECDC. I think that we have no need to, yes. Yeah. Okay. So you are from ECDC, so I let the floor just to introduce you and let us understand the link with the JAMRAI activities.
Thank you so much, Rita. So yeah, my name is Diamantis Plachouras. I work at the European Center for Disease Prevention and Control. I'm currently acting head of section on the microbial resistance and healthcare-associated infections, and of course, virtually every area of JAMRAI work has something for us, because at ECDC we're working on surveillance of antimicrobial resistance, antimicrobial consumption, and healthcare-associated infections, but we're also working with scientific advice and country support on AMR. We're also working on, we have some training activities. We are also doing risk assessments and looking at event-based surveillance, for example, through looking at outbreaks in Europe of either emerging antimicrobial resistance or specific healthcare infections. So everything that JAMRAI is doing is relevant for us. And I forgot to mention communication, which is also very relevant in our area, and for example, with the European Antimicrobial Awareness Day, which is basically a milestone for ECDC work every year. So we had the privilege from the beginning to work with JAMRAI partners, even from the planning stage. And we have been collaborating quite closely, more with some work packages, a bit less with other, but eventually we have been involved almost in every area, especially concerning human health. For example, in the area of infection prevention and control, where we were lucky enough to have JAMRAI support because we have been working on development of infection prevention and control guidance. So JAMRAI has supported this work, for example, through the systematic review and recommendations on diagnostic stewardship, which is part of this guidance, and also a very important support has been through the development through the update and review of the ECDC Director of Online Resources for Antimicrobial Resistance, Antimicrobial Stewardship, and Infection Prevention and Control. This will be a complementary work for the IPC guidance, because the guidance that we will be developing and we will provide to the European Commission to finally publish as in probably sometime in 2026, probably in June. This refers mostly to components of infection prevention and control programs, and how to establish and implement such programs. And then the Directory of Guidance will provide all the more granular guidance specific on specific infections or microorganisms. We have also worked together with microbial stewardship, and we have supported the work of the respective work packages, both for primary care hospitals and long-term care facilities. And this is also very, very important for us, because appropriate antimicrobial use is central, is key for the control of antimicrobial resistance. And I think there are also further, and also very importantly, and we'll probably talk more about it later, the work on behavioral change for antimicrobial resistance on infection prevention and control. This also has been very central in the guidance that is being developed, because I mean, implementation is basically the bottleneck right now. I mean, we have very good data in Europe. I think we are privileged to have very good data. There is room for improvement, of course, especially at the local level, but we have good data. We have the evidence. We know what works. We have also guidance. There is guidance. The problem is implementation, and I'm happy to talk about it more later. And finally, I would like to say that the work on behavioral change will also guide and inform our further work on practical operational application of behavioral change insights from behavioral change science and implementation science in the implementation of guidance.
So thank you very much, Diamantis. There are a lot of things of which we
talk all day.
Yeah, absolutely. So it's my pleasure to call here Boumediene Soufi from Medicine for Europe. You are here representing Medicine for Europe, so please introduce yourself and your organization, just to let know what is your activities and how their activities are linked with the JAMRAI project goal.
Yeah, absolutely. Pleasure to be here. Good morning, everyone. So I'm going to try to make sense. I have to admit this light's going to be a little bit of a challenge, so maybe someone should actually push the black button and see if this reduces the light strength. Yeah, pleasure to be here. So my name is Boumediene Soufi, but feel free to call me Bo for short. I am the global head of the antimicrobial resistance program at Sandoz, which is one of the members of Medicines for Europe, and I'm very proud and privileged to be able to represent Medicines for Europe today. So Medicines for Europe really is the voice of the generics and the biosimilars industry, and Medicines for Europe really strives to ensure the access to patients to responsible use of these medicines, but also to ensure that Europe has access to quality-assured, affordable medicines, while in parallel ensuring that the healthcare ecosystem is sustainable for generations to come across the continent. What I would really like to deliver to all of you today is, hopefully, if it's one takeaway message, it's that access and stewardship are the same side of the same coin. We cannot steward things that we don't have, and we need to ensure that the market framework is resilient and rewards supply resilience, so that ultimately clinicians have access to the first agent that's most beneficial to the patient, right? And avoiding this escalation to broad spectrum use. Because ultimately, even before we talk about resistance, the first question is, we need the market framework in place that makes sure that the agent that's needed for the patient treatment to have the best outcome is there, full stop. Then, of course, the second element is, by avoiding this escalation to broad spectrum use, we can avoid any sort of exacerbation or complications on the resistance side of things. So number one, we need to make sure, whether it's a reserve antibiotic or a narrow spectrum antibiotic or low volume, does not matter. It's the right treatment for the right patient at the right time, independent of what country the patient is in. So that's kind of the angle that I would like to talk about with all of you today, and also with the panelists. So looking forward to the discussion. Thank you.
So thank you very much, Bo. We will come later on this matter, this issue. It's my pleasure to invite Johan van Eldere from European University Hospital Alliance. Again, introduce yourself and, as you prefer.
Good morning, and thank you for having me. My name is Johan van Eldere. I'm here on behalf of the European University Hospital Alliance. We are a fairly young organization, and we include 11 of the largest university hospitals in Europe. For example, here in Vienna, the AKH University Hospital is our member. Yes, so again, my name is Johan van Eldere. I'm here on behalf of EUJA, European University Hospital Alliance. We're a fairly young organization, including 11 of the largest teaching and research university hospitals in Europe. Our aim is to support the sustainable European healthcare system. A European healthcare system that is distinguished by the fact that it delivers top clinical care, is based on research and innovation, and is equitable, meaning that it has equal access for everyone, whether you be rich or poor. And don't be surprised, but this system is under pressure. There's a lot of pressures on this system. There's the workforce problem, there's demographics, there's the increasing price of drugs, especially in the cancer field, and there's the geopolitical changes. And so what we want to do is to take action, to do projects, but also to be advocates at European level for the sustainability of healthcare systems, European healthcare systems. And this brings me to AMR. AMR, antimicrobial resistance, was not one of our priorities. And my main point today is going to be that for hospital managers, antimicrobial resistance is not a priority, not a priority. And if there's one advice I could give you, that is, make it a priority for hospital managers. I mean, I've seen a lot of very good initiatives talking about IPC teams, talking about all other people in the hospital. They're convinced you don't need to preach to the converted. What you need to do is preach to the hospital management. And again, AMR is not a priority. There's many other priorities: the workforce problem, cybersecurity, the green transition, resilience, preparing for war, preparing for the climate change, and everything else. AMR is not on their priority list. So what you need to do is make it a priority. And this will include looking at ways to convince hospital managers that an advice of an IPC team is not a nice to have, but is a must follow. That IPC teams need to be supported, and that their advice is not there just to have, but is there to be followed. I think that will be my main message today. And just for full disclosure, I used to be a microbiologist, and I'm married to the head of the IPC team in my former university hospital, who's at Leuven.
So, thank you very much, Johan. You anticipated a lot of things that we can discuss in a few minutes. So it's my pleasure to call for Camelia Bogaert from IPC Nurse Corner. So thank you very much to be here. Please introduce yourself and your activities.
Hi, good morning, everybody. Yes, I'm an IPC nurse. I work in an acute general hospital in Belgium. And as an IPC nurse, I see in the daily practice that infection prevention and antibiotic stewardship activities live or die at the bedside. Because we have guidelines, we have a lot of guidelines, we have good guidelines, we have books of guidelines, but actually there at the bedside it happens or it happens not. So, yeah, when I realized that as IPC nurse, I started to look for, to connect with people, to see how we could improve that implementation at bedside. So I did my UKIC training, and during my UKIC training, at each module that I've have been to, I asked, could I meet your IPC nurses, your local nurses, to talk to them, to ask them how do they implement guidelines in your setting. And from that, going through the modules and then finishing my UKIC training, I got the idea to create a network of IPC nurses that communicate on a low-level manner. So we actually created an IPC nurses network this year. This initiative is under the umbrella of ESCMID and EU-JAMRAI. It seemed to us the best way to create it under the umbrella from EU-JAMRAI as a part of the activity of EU-JAMRAI, and not to create some separate initiative, some separate website somewhere where nobody could find it. So that's one message. Let's bundle our strength. So you can find that page there. And so what is the purpose of this initiative is to really translate or to see how different nurses from different settings are implementing things. The main issue that we encounter in everyday practice is that new guidelines, new reports are arriving on a level that is already overloaded. My IPC physician and my AMS physicians have already a full agenda. They receive guidelines, 40, 50 pages that they have to make time to read them. Sometimes those guidelines are given to the nurses also to read, but not always. In not all the hospitals is a good communication between physicians and nurses. That's something that I think it should improve in the future. And there's one more aspect. I would like, in an ideal world, to make more friends between IPC and EMS. Let's try to build a bridge between IPC and EMS because, I mean, the two are, it's important to create that bridge. It's important to create it not only on the physician's level, but also on the nurses' level. Nurses don't dream about prescribing medication and about other difficult stuff. They just dream about understanding why some decisions have been made for patients. Because if they understand that, then they can support more, even more from IPC side, the success of those decisions. So, happy to be here, happy to join the discussion.
Thank you, Camelia. Really very inspiring. Again, the implementation is the key word of this roundtable. And it's my pleasure to call for Jette Nygaard Jensen from Imagine and give you the floor just to introduce yourself and the activity of your association.
Thank you. Thank you for the organizers for inviting me. My name is Jette and I'm from Denmark. I'm a senior researcher, and the reason why I've been invited is because I'm a representative from the project called Imagine. Imagine stands for Improving Antibiotic Use and Infection Prevention in Long-Term Care Facilities. So I talk from the context of long-term care facilities. And Imagine, I just want to say very little about the Imagine project. It ended 30 days ago, and it was a 3-year EU-funded project. And it was the aim of Imagine was to improve infection prevention and antibiotic stewardship. So there was 2 in 1 in this project, IPC and antibiotic stewardship. And the results of the 3-year project here, Imagine, were good. We managed to improve 17 out of 29 IPC elements significantly. We also managed to reduce the number of UTI-treated and antibiotic-treated UTIs with 27%, and we reduced the unnecessary antibiotic with 13%. Very good results, and we are very proud in the consortium. But we were also very relieved because many of us in the Imagine consortium has also done another EU project, another 3-year EU project called Happy Patient. It ended about 2 years ago, and the results from Happy Patient in relation to antibiotic use in long-term care facilities, they were not good. Actually, in one of the 5 countries that participated in the Happy Patient project, the antibiotic use increased after our project. So bear in mind that we were very proud that the Imagine project had so good results. And if you are going to ask me, which I hope you are, why did you get so good results in Imagine? How did you manage? My answer will be, that was because we included the end users from the very start of the Imagine project. The end users were participants from 8 countries. We were 8 countries in Europe, and we were more than 400 professionals, long-term care professionals. They were included from the beginning, so they were a part of the participation process. They were deciding what we should investigate and what decisions we should make, and also what analysis and what tools, what we should develop and how we should implement. And so I think that was the word from me. Yes, thank you.
Thank you very much. Thank you very much, Jette, for this inspiring speech. And let me introduce, if is linked, Dr. Pilar Astier is online, perhaps, we hope. So Pilar is from WONCA. Are you there, Pilar? Probably not yet. Okay, maybe we can wait for Pilar, for the Pilar link. I think that we have a lot of...
Can you hear me?
You are here, so...
Yes! I've been listening
nice.
to you.
Welcome, Pilar, to our meeting. We are very happy that you are here with us. You are from WONCA, so please introduce yourself and the activity for which WONCA is related to the JAMRAI project goals. Thank you very much.
Thank you. I would like to...
There is some problem with the audio.
Hello again?
Yes.
Now it's work?
Yes.
Good morning to all participants in Vienna. I would like to thank you, the JAMRAI committee, for the invitation to the Global Organization of Family Doctors worldwide. I apologize for not being there in person. I'm grateful to the technical team is making this digital connection possible. It's a privilege to share this panel with such a distinguished group. Thank you, Rita, for moderating, the Diamantis, Boumediene, Johan, Camelia, and Jette. Nice to meet you. It's truly a kaleidoscopic human perspective for antimicrobial stewardship, spanning from the epidemiological surveillance of the ECDC to behavioral insights of the imaging team, as Jette said, and my presence here with the family medicine perspective. I'm Pilar Astier, specialist in family and community medicine, and also a specialist in preventive medicine and public health, and I work as a frontline family doctor in Zaragoza, Spain, and also a professor at the University of Zaragoza. I've been working with clinical risk management and implementing healthcare quality models, contributing to patient safety through elaboration of national and international strategies, and also recommendation for antimicrobial stewardships. My research career is focused mainly on translating complex safety research into practical data-driven tools that empower primary care teams to provide quality and safer healthcare. That's the meaning of the EU-JAMRAI 2 now, from paper to practice. So family doctors, we are working in primary care team with nurses and pharmacists. We manage the human perspective of the One Health access across life course, from the first pediatric fever to the complex infection of the elderly. This longitudinal connection is our most powerful tool. Throughout my career, I have come to view that antimicrobial stewardship is a fundamental patient safety intervention is key. So WONCA mission today is to advocate for a transition from paper to practice by ensuring the safest prescription possible is supported by a resilient primary care team-based system approach. So WONCA stands for enhancing the role of family doctors in primary care through training about antimicrobial stewardship, doing research on the implementation process as the Imagine project is launching now, the results, and also to quality performance accreditation process of our primary care facilities around the world that will enhance this specific optimization of antimicrobial prescription options. So I appreciate deeply the invitation to have family doctors on this panel as we implement this optimal prescription of antibiotic every day. Thank you.
So thank you, Pilar, for your intervention. Thank you very much. So it's time to go deeply, and I would like to pose the first question to our panelists. I give the floor one by one, and we ask you to help us to focus on challenges before. So we are now witnessing a lot of changes in our healthcare system. So there are many challenges that I think we can see in infection prevention and control and in antimicrobial stewardship. So first of all, which are, in your opinion, the main challenges that we are witnessing now? And try to let us help in what are the challenges that we need to resolve or to afford, especially as JAMRAI project want to do. So first of all, Diamantis, challenges and also the way to meet those challenges. So some ideas.
Thank you very much, Rita. I think we already have somehow pointed out a number of challenges, and it seems we all agree that one of the main challenges is implementation, but of course there are some other systemic challenges that perhaps they need more an overall overarching approach. So we heard about staff shortages, which is a key issue across healthcare systems in Europe. And these staff shortages lead also to work overload. And this is not a perfect condition for appropriate antimicrobial use or appropriate infection prevention and control. And there are also, there are also often lack of funding, both in the healthcare system, but also in public health. And we have seen that, especially after the pandemic, that funds have shrinked a lot in public health. Excuse me. And but eventually, I think there are also areas that there are things we can do, and where JAMRAI has been working on, and this brings us back to the implementation challenge. I think it's very telling that we know, for example, the effectiveness of hand hygiene. Right? I mean, there is no doubt how effective hand hygiene is, and yet what we see is that appropriate hand hygiene only happens in around 40, in the best cases probably 40 to 50% of opportunities for hand hygiene. And in some places this is even lower. In some places are privileged to have higher compliance, but eventually this is one of the biggest problems. And I think it highlights that the main challenge is implementation. So we know what has to be done, but somehow we have failed to make it happen at the bedside. And that's why I think it very important, one of the strong points. And for implementation also, we know that a number of factors play a significant, considerable role, but behavior is key. And that's why the work and harnessing the insights from behavioral sciences and harnessing the insights from implementation science is very important in this area. So we need to make sure that we work together and that we bring in the field scientists with knowledge on behavioral change and implementation science to support work and interventions that really work and make a difference. And this is important both for infection prevention and control, but also antimicrobial stewardship, because these are the two key elements that are necessary to fight antimicrobial resistance.
So thank you very much. This is, I think, an aspiration summary, I think, also for JAMRAI project. So you mentioned some very easy to understand challenges, but also a pathway for working and for meet needs. So implementation science and all the part of the project that are working on behavioral changes. And yesterday we saw a lot of deliverables and products that are going towards with this purpose. So very interesting. So I give the floor for the same summary for Bo, for the medicine and Europe, for Europe perspective.
Thank you very much, Rita. So obviously there's a lot of challenges, we know them. I would like to call out 4, if I may. So we'll try to keep it to 4. The first one is that resistance is rising where it's hurting the most. We heard from Christine on day 1 talk about the rise in bloodstream infections across the EU, especially in those very serious multi-drug resistant carbapenem organisms, and of course that undermines the power of AMS and IPC efforts on the clinical side. The next 2 really come down to our market framework, right? So you mentioned shortages. We remember the recent shortages and just the dramatic, terrible effect it had, especially in the pediatric population. They still happen. They're still recurring. That's directly threatening the efforts of stewardship, again, because you don't have it. And of course, when you look at procurement policies, they're very restrictive. It's undermining the importance of supply resilience. So why is that happening? On one side, when we think about costs to manufacturers, what's essentially happening is cost of goods is increasing, inflation is rising, energy costs are rising, as well as regulatory costs. And so you have this cost pressure on one side. Think of it like a formula. Now add the fact, on the other side of the equation, you have pricing pressure. Pricing pressure on the manufacturers. Why? Because of restrictive procurement policies, also pricing policies. And what that essentially does is it puts pressure on the manufacturers, and you see a market consolidation effect occur. Less marketing authorization holders, manufacturers are exiting, and the critical medicines we need, the first-line treatment therapies, either become limited to one marketing authorization holder, or unfortunately, in some cases, completely exit the market. And so this, of course, increases the risk of shortages. Why does that matter? Because ultimately, what we're doing is, if we're losing the power of these first-line access antibiotics, essentially what we're doing is we're reducing the effectiveness of the treatment to the patients and increasing resistance, again, as I mentioned in my introduction, because of this pressure on, more broader spectrum use, right? And ultimately, it's the patient that pays the price, right? And the last challenge, I would say, is a delinking, if I may call it like that, between AMS and IPC targets and controls with the AWARE goals, right? So the AWARE classification of antibiotics. The European Commission has stated, at least 65% or more of prescribing should be the access group of antibiotics, a narrow spectrum first. And this is, caused by, let's say, guidelines not being followed across the board, or a lack of sufficient data that basically, increases these gaps. So I would say, from a challenges point of view, those would be the main ones I can highlight. And of course, it's not all bad, so there's progress, right? And I guess we'll come to the progress in a second, but those would be the main ones that I see.
Thank you very much, both. Sorry, do you have some practical examples on how the drug shortages can impact on antimicrobial stewardship in Europe, for example? Just one or two examples.
Yeah, absolutely. So we did this analysis. If you look at all shortages that occurred between 2023 and 2024, actually 2 out of 3 shortages had a low marketing authorization count. 2 out of 3. And these were all critical antibiotics, Pen-Vs, amoxicillin, and a really, really bad impact on the pediatric formulations especially as well. So the facts are shown, it's there. Shortages cause a direct correlation between market exit and an impact on stewardship. So.
Yes, thank you very much, thank you. So the floor to, I think, to Johan, just to respect the order. Challenges, again, how to meet the needs, and especially focusing on what you are saying. So antimicrobial stewardship and IPC are not a priority now in our hospital management and also governmental vision. So this could be considered a main challenges or not?
Absolutely, and so the question is how to address this. Implementation, of course, is the buzzword that has already come up several times. I heard this thing about behavioral change and everything. I think to change things you need the stick and the carrot. Let me tell you a little bit about the stick. First of all, yesterday I heard from Michael Borg that the system is dysfunctional because it doesn't address this problem. The system is not dysfunctional. The system is functional because AMR is not a priority. It's not within the system. Yeah. That's logic. So how do you get AMR in the system? Well, there's also a big responsibility, and I think that is something JAMRAI could work on, in terms of the politicians and the public perception of AMR. It needs to increase. And there's one argument that I haven't heard the past 2 days, and that is that there's a clear connection, and there's been meta-analysis to show this, there's a clear connection between people losing faith in the healthcare system and people voting for extremist, non-democratic parties. So can you imagine a future where people would fear to go into a hospital because of being contaminated with multi-drug resistant organisms? So this argument that AMR is also something that is not the only reason that people would lose faith in democracy, but could be one of the reasons that people lose faith in democracy, is a powerful argument that is not sufficiently used towards politicians, towards the general public. The second point I would like to make, that is hospital managers are there to balance the books. So at this moment, whether you like it or not, antimicrobial resistance is not something that is important. In many countries, it's even an advantage of having people for a longer time in the hospital. So all these studies that show that AMR is having an enormous impact on the costs of healthcare, yes, but not at the hospital level, or at least not in all countries. So how can we convince hospital managers to make AMR a priority? Well, one of the things we will be trying to do within our alliance, we regularly get all our CEOs together. One of the things that I found appeals very much to CEOs is to benchmark what is happening in their hospitals. There's no CEO that likes it when, the benchmarking shows that his hospital is lagging behind these other big university hospitals in terms of something. Immediately, he will go back to his hospital and say, this needs to change. So what we will be doing, for example, one of the things we would like to do is to see how are IPC measures, antimicrobial stewardship, how are they implemented? We're not going to look at the levels of AMR. There's too many variables that play into it. But how are IPC measures implemented in your hospital and benchmarked between our hospitals? And we think this could be a powerful initiative for CEOs to accord more importance to IPC. IPC is not only about IPC nurses, it is also about the design of hospitals. Our hospitals at this moment are not designed to combat AMR. We're evolving slowly towards single patient rooms, but still we have waiting rooms where patients mingle, where there's probably an enormous spread of AMR-resistant pathogens. Do not forget that, especially in our university hospitals, we care for the most fragile patients, often with many multi-drug resistant organisms. And another issue is that we need to make AMR more of an issue when we train our specialists. There's lots, and this morning we already discussed this. I've taught microbiology and antimicrobial resistance at undergraduates. Do not think that when they arrive in the last year of their medical training, they still know what I taught them in their third or second or whatever year. It's at the level of specialist training that habits are made. It's their colleagues that will tell them use this or that or something else. And there we have more impact if we can there oblige them to use the right antibiotics at the right time. That will have a major impact. And maybe one last advice. I've seen a lot of data in the past 2 days. Data without action is distraction. You really have to do something with these data. I've seen so many European projects that said, we're going to create a website, we're going to create a dashboard, we're going to create guidelines. Almost every European project tries to do this. It is, as already been mentioned by other speakers, there's so many guidelines, there's so much information. Please try to put it together with existing ones and come to a harmonized website or dashboard or whatever with the scientific organizations, but do not add to the overflow of information that is already there. And this leads me to my last point. You put a lot of emphasis on IPC and AMS. It's true, but again, you're preaching to the converted. And one of the things we learned after COVID is that if you put more emphasis on the responsibility of people in the hospital, people that already have given everything they had during COVID, you chase them into burnout. So be very careful, but what you add to IPC teams, be mindful of the fact that these are people that are already putting a lot of effort into what they are doing. Try to address the other people that need to give the IPC teams the means and the people and the funding that is needed to do. And maybe as a last example, one of the hospital directors of a big university hospital in my country had to resign because he didn't follow the advice of the IPC team, but only after there had been problems in the intensive care unit. So IPC advice should be a must follow, not a nice to follow, when the management thinks it is useful.
Thank you very much. Again, a lot of things to reflect even later. Thank you very much for the pragmatic vision. And okay, so I leave the floor to Camelia for challenges from your perspective and also how we can meet needs.
Okay, so you heard a lot about the global and European problems and big hospital problems. I will go back to my micro implementation level in my suggestions. So I had a discussion with a physician, with an infection prevention physician during ESCMID 2026. And I asked him about how his team is functioning and challenges that he has. And he said, yeah, we should try to do something about our nurses. I mean, how are you like that? And which courses did you do to dare to speak to us? And because my nurse it's like happened yesterday, she came back from a meeting about a new building ward, and she was almost crying. Why? Because there are a lot of resistance from the builders, from the management, from the hospital. Why do we have to do that? Why do we have to have ventilation? Why do we have to have a wall or not to have a wall somewhere? And the IPC nurses are sometimes alone in this kind of meeting. Huh? And I told him, And why don't you go with her from time to time to these kind of meetings? Why do you leave her to be exposed to that? So it's not a criticism to physicians, not at all. But it's actually something that I implemented in my own hospital, because Diamantis talked about hand hygiene compliance. And as an IPC nurse, I have to go to do the rounds for hand hygiene observations and for basic hand hygiene, the basics from the hand hygiene. And from time to time, I have some physicians or persons with resistance, meeting with resistance. I have 90% compliant personnel, and I have 10% which are hard resistant. So I said this year to my physician, you will come with me to the next round. I don't care about your full agenda. You will come with me and we will go together on all the wards, and you will talk to your colleague physicians, because they don't listen to me. They need to hear it from you as a physician. And it worked. It works so much better. So I think I have a suggestion about challenges IPCMR: accountability and supporting each other. When you write those guidelines, try to make also the short versions of it. You know, when you look in one pager, you have 30 pages of why we are doing something and all the evidence and all the explanations. Try to add one page about we do that, and that. And in that one page, try to add also the accountability. The physician does that, the nurse does that, and the patient does that, because that's a huge hole about involving patients in IPC and EMS. And we need those tools. That is what we need in the practice. We need a translation of that guidelines to the practical part. And we need accountability, because there should be done. And the question is in the practice, who is the person or the profession that should do that? And how should we do that? So I think there needs to be some more cooperation, get the physicians out from their lab to go to the rounds, and get us some more involvement, work some more together, and when you write something, put it there who has to do it. So
thank you very much again. Other suggestions for thank you. Other very useful suggestions for also for JAMRAI project. Thank you very much also for us, for end user. And I give the floor to Jette.
Yes, thank you very much. Like you, I also have one word. You had accountability. I also have one word for this. But I would first say that I've been here the 2 first days, and I've been very impressed about all the good intention and plans about implementation and how to move on further. So I thought, well, what can I say that has not already been said? And one word comes to my mind when it comes to implementation in long-term care facilities, but also in other facilities, and that is sense-making. You were also talking a little bit about it, but sense-making is so important for the end users. They need to understand why they have to follow the IPC guidelines, or why they should not give antibiotic or initiate antibiotic treatments. Let me give an example from the Imagine project. In the Imagine project, we made this IPC audit, and the results from the 8 countries showed that in most of the countries, the nursing home staff, about 60% of them were wearing rings, jewel, they had long nail polish, they had long nails, and that is an absolutely no-go. I'm not an infection control nurse, but my colleagues say that is a no-go. And how can we intervene for that? Of course, we can tell them why they cannot have nail polish or wear rings or jewels when they take care of the resident. We need to make that clear for them. That was one example. Another example is also that in Imagine we looked at the antibiotic use, and nursing home residents, they are treated for UTIs very much. And what we measured was that about 55% of the treatments for UTI, they were unnecessary. And why is there so much unnecessary treated UTIs at nursing homes? We could look at the indicators or the signs and symptoms of the residents. One of the most prominent symptoms for UTIs were confusion. Then you had fever, smelly urine, but that's not very specific symptoms for a UTI, but the nursing home staff, they associate it with a UTI. So you also need to tell them and to guide them and say that this is not real symptoms, but it has somehow become a culture. So I think that it is important to make it very clear why it makes sense. All these good projects and intention, we need to be more clear and more specific, because that's also how we can engage, and then the implementation will be a success.
Thank you very much, Jette. Another key word is sense-making. And thank you for the perspective really from end users, even with the last example. Thank you very much. So I give the floor to Pilar, if she's here, just to let us know which is her perspective on challenges in this moment, and what we should do to meet the needs that we perceive.
Thank you very much. I completely agree with Jette from the Imagine project. The sense of making is really relevant. The central challenge we face in primary care teams around the world, as well as in Europe, is a daily implementation gap between guidelines and day-to-day practice. Currently, there are different issues that we need to address to reduce this gap. On one hand, we need to invest in post-COVID educational research. Family doctors have a central role on antibiotic stewardship. We need to support family doctors, and particularly family medicine residents and primary care nursing staff in returning to diagnostic parsimony, moving away from the broadest spectrum caution of the pandemic to a better performance based on rapid tests, epidemiological context, and to adapt the treatment to patient health risk based on the accessibility to electronic health records, previous antibiotic resistance profiles. And moreover, we need to improve primary healthcare health information systems with easy access to guidelines and decision support tools to improve antibiotic prescription and to improve IPC recommendations, alerts, pop-up measures, so we can have easy access on the electronic medical record and electronic prescription record. We also need feedback. The health professionals, we need feedback through patient safety and quality indicators to set up goals on specific infection disease treatments along time. We have some organizational barriers too. We cannot change behavior without addressing time constraints. As Jette agreed, from psychological perspective, the pressure of a few-minute consultation often drives just-in-case prescribing, and we need to assess as well IPC measure implementation with audits, observational implementation of IPC measures within primary care teams. We need rapid point-of-care diagnostic tests to support our team's decision-making, considering prescribing or symptomatic treatment and watchful observation instead. And also the fact of leading with patients' expectations to have a quick recovery from infections problems, because they have the belief that antibiotic use may lead to a quick recovery. Finally, we have to engage again the community to sustain infection prevention and control together. We need to support guidance with primary care nurses and our community activities with community stakeholders, means social prescription strategies, therefore to raise awareness in civil society that can act on infection prevention and control activities in all the health system continuum. It also will reduce environmental resistance and, of course, the ecological impact of wrong use of antibiotics. Thank you very much.
Thank you, Pilar. Thank you very much. So I think that we have the opportunity to have a second round of opinions and suggestion and intervention. I write some keywords that I think raised from the first round. So first of all, implementation, this is the keyword, and probably we go deeply in this, the meaning of implementation. Accountability, sense-making, easy accessibility, benchmarking, rapid diagnostic. So probably there are many other keywords, but these are something that probably can drive us to the next phase of our roundtable. So I would like now that you can underline or stress how we can go from the papers, guidelines, amount of books of papers to the practice, to the end users. So how we can use some of the many of the products that we have seen now in these days. I take some notes. We have seen videos for communication. We have seen dashboard. We have seen platform, not only guidelines. We have seen a lot of work on implementation methods that I want from you to understand how can be useful. So how can we help JAMRAI to continue this big effort to go from the papers to practice? Looking at implementation, I think that we can identify, I think, three pathways. One is implementation from, for example, JAMRAI products to end user. Okay. One is the implementation from end user to the practice, because this is the main issue of implementation science, how the implementation science can educate end user to change behavior, but also something raised about how to implement, how to let an implementation with hospital management or governance, because also in this case there is a very big need. So just some of your opinion on how to support the passage from papers, from theory, from guidelines, from amount of books to the real practice for us, for end users.
And again, no, thank you so much. I think this is a key question, and I think there are three components that I would like to point out. First of all, that whatever is done has to cover a need of the end user. So this is the, I think, a prerequisite that it will be useful. And I think on this, JAMRAI has done a lot, because first of all, I mean, JAMRAI has among your ranks many end users, and I think this is very, very important. And so it has to cover the needs of the nurse on the bedside, of the IPC professional, of the prescriber. And I think this is one of the key factors that will, in the end, guarantee the usefulness and the applicability. The second is, I think, building up on what already exists. And I think we've seen very nice examples these few days. Yesterday we heard about that JAMRAI actually supported a course on antimicrobial stewardship that was developed by a previous EU-funded project, the Drive AMS, for example. I think this has been a very good example of how to multiply the value of already existing work. And there is a lot of good work that has been done in Europe. And I think it is excellent that JAMRAI has been really building on this. And I think another example is obviously Imagine here, and I think there is a lot to be gained from this. And these are actual projects, interventions on the bedside together with the end user. And this is a really amazing strength of this work. And the third is to take advantage of synergies. So we see how many actors we are sitting already here, and there are so many more. Many of you are sitting in the chairs of this room, and we are all working with a common aim, with a common target. Coming together and working together and using and multiplying the work of each other is key, because we need to reach an audience that is really very broad across Europe. It's the healthcare providers, it's the hospital administrators. We've heard about the importance. It is also the public. So the synergies, and here, for example, I'm thinking about the work on European Antibiotic Awareness Day and all the excellent work on communicating AMR that we heard about yesterday. And I have been thinking since last evening how we could actually make this come together, and so that each one supports each other, because then we will see really much stronger effect. Thank you.
Thank you very much.
Thank you. So look, I think the EU-JAMRAI 2 initiatives have been so useful. We need to applaud everyone in the room. It's the right thing to do. Why? Because it's focusing on implementation, but with the One Health approach in mind. So when I think about, and it was already said, how do we translate these practices to policies and make sure it gets to the bedside? Because ultimately, that's the question. Number one, link the IPC and the AMS targets with the European Commission's recommendation on this AWARE following, right? So 65% or more should be prescribed in the first-line access group of antibiotics, and also this 2030 target to reduce the consumption by 20%, number one. Number two, make sure clinicians continue to have access to what they need when they need it. So now I'll be the optimist. We're seeing progress in some areas. We have the Critical Medicines Act that is trying to fix this issue with tenders by employing this most economically advantageous tender criteria, which is really important because it looks at things beyond just price. It looks at environmental factors, quality assurance, reliability. Very good, but we can do more. Keep the HERA and EMA shortage monitoring mechanisms in place. Super critical, keep it. Right? Because we've seen in the past what happens when we have a demand surge coming from seasonal variations, right? We cannot be in a position to have our clinicians be forced to use something that's not optimal. So keep that mechanism in place. Make sure we have supply resilience. Keep the production of these critical antibiotics in Europe. Invest in it, from the API to the finished product. Make sure that we are capable to continue to produce here, right? It's really of utmost importance. And this allows the manufacturers to stay, to produce what is needed, but also to reinvest, right? So it's a continuous circle there. And I would say the last part is, and the key word was already mentioned, I'm gonna resonate it because it's completely true. If you wanna make EU-JAMRAI results alive, it's accountability. Accountability to the politicians. Make sure the IPC and the AMS targets are implemented into policy. Accountability to the hospitals. Make sure they are following this, that the efforts are helping the national action plans, right? Filling in the gaps between guidelines to practice that ultimately lands in the bedside. and accountability also to politicians to make sure that AMS and IPC targets can only be, effective if we ensure that the market framework is focusing on access. So link access and stewardship together, they're one and the same. That's how you make progress. And also we see, I'll continue on the optimistic side if I may for a second, we see great efforts here. Look, we heard about the guaranteed revenue model that the Nordics are doing. That's what we need more of, right? Harmonize the guidelines, figure out what is the true need that the antibiotic is used for what indications, build up that capability to sustain these essential medicines. Fantastic. We need more of that across Europe. And as we heard, I hope more countries jump on board. That's what we need, right? So I think the key word is accountability, make sure we have access to what we need when we need it. But also, ECDC, for example, amazing data that comes out. Can we be proactive instead of reactive? We all know how difficult it is to predict resistance, but can we use the data that ECDC gathers to say, okay, in a scenario, if resistance goes in this trend or that trend, what is the product portfolio that we would need to address these new resistance challenges? How would AMS and IPC actually need to be changed in light of these, resistance changes? Now, I understand it's very difficult to predict, but at the same time, we have to be as proactive as possible because we see what happens in the past when we're reactive. So I'll leave it there. Thank you.
Thank you. Thank you very much.
Thank you. It's becoming increasingly difficult to say something that hasn't been said before. So what I will be saying will be, to a large degree, a repeat of what's already been said. The first thing, again, is when you're making your guidelines, your dashboards, your websites, try to synchronize and harmonize with other organizations that are active in the field. Think about ECDC, think about EMA, think about ESCMID, think about all the other organizations. If there's one thing that Europe suffers from, it's over-administration, over-regulation, too many pages. And, healthcare providers are like clinicians, like politicians. They like to read, but they don't like to turn pages, if you know what I mean. So keep it short, stupid and simple, and synchronize it at European level. The second advice is try to get it into European regulations on the European agenda. Europe, whether we like it or not, is playing an increasingly important role in healthcare in many different fields. We know that healthcare is still a national competence, but Europe has the right to intervene where they are complementary to national competencies. And so we see this in all different fields. We see this from the MDR, the IVDR, the Artificial Intelligence Act, the Critical Medicines Alliance, HERA, GDPR, you name it. Europe is increasingly important in healthcare. So try to find a way to put AMR, the narrative of AMR, at a European level. Put it into quality. Quality is an increasing thing that Europe is being involved in. Try to get it into resilience. Resilience of healthcare is flavor of the month in Europe. Healthcare systems being prepared for shocks. Make AMR a part of that narrative. And that is my last advice, also make sure that AMR is a narrative that touches the public, because the public motivates politicians, and politicians motivate how healthcare systems reimbursement are organized and how advice is being followed or not followed. So make it a public narrative. It's been on the agenda a couple of years ago, it's again going down. How to make AMR again a national public priority is going to be extremely important and something I think this alliance should be working on. So that would be my advice.
Thank you very much. Thank you again. I'm thinking to the very nice session of yesterday about communication, how much antimicrobial resistance could be included also in experience or initiatives for public. So thank you very much. The floor to Camelia. You have
Yeah, I would just like to pick in for an analogy on what I already heard here. Don't preach to the converted. So let's talk a little bit about those converted people, the converted people who are reading the Bible. We are the converted people and the Bible. We all know the Bible. You have the apostles, you have Lucas and John and all the other. One thing about that, the Bible is the same. Stayed the same during the last 2,000 years or more. So if you would compare that to WHO, to ECDC, to local Cienzano, Babcock, other people who are making guidelines, ESCMID, EU-JAMRAI, these are all apostles which are publishing, still publishing and producing materials. And the converted people don't have time to read them during their work hours. They mostly read them in the evening or early in the morning, or on Sunday instead of the Bible, I don't know. But yeah, I mean, what you said, it's really like important, and don't take it as a future something to try to synchronize these references and these sources of information. Try to do it like from Monday on, you know, Monday now, 2nd of February. Try to make a team to synchronize ECDC and WHO and EU-JAMRAI published materials. I mean, they all have their graphic teams, then they all have their writing teams. Let's make one, you know, one channel of information so that the converted people has only one Bible to read. And not all the versions, and because we are not able to keep up. I mean, I appreciate immensely every materials that you make in EU-JAMRAI. I appreciate a lot the ECDC materials. I just don't find the hours and the time to keep myself updated with everything that it's published on those websites. If it would be one, it would be manageable.
Thank you, Camelia. So again, from Jette, from
Yes.
papers, guidelines to practice, your
Yes,
opinion.
I would like to continue where I ended before, because, you know, I talked about that we saw big challenges with rings and long nails, and when we presented the results from the countries, the participants, you know, we involved them from the beginning. We said, how can we solve this problem? And they didn't say, we would like to have some guidelines. They didn't say that. Instead, the solution of this was that we made posters. We made, yeah, you would probably say, Johan, dumb posters, simple posters. We made one poster like this with a drawing of a hand with jewels and rings and germs. Then we draw germs on them. And then they hang it up on the nursing homes. Also, another poster we made was 8 myths about gloves, because they had a awful use of gloves. You know, sometimes they just reuse the gloves. They they hand sanitized their gloves, or they put on 2 gloves just to be sure. So we made a poster, 8 myths about gloves, telling that this is not the way, because you think you're more safe when you use 2 gloves. You're not. You cannot be completely sure that there are no holes in your gloves and so on. Anyway, so that was what the end users, they asked for. They didn't ask for guidelines. They asked just for simple communication. And also bear in mind, as I said in the beginning, we saw significant improvement in 17 out of 29 IPC practices. So actually, simple communication can be very effective, I think. Anyway, but I was now going to say something about what would I like to give as an advice or something to JAMRAI from my perspective, long-term care facilities, and I have also 3 points. I've noted that it's popular with 3 points. I have less is more, I have pedestal, and then I have time. They come in alphabetic order. And less is more. It's because that in the Imagine, the main intervention was a 2-day physical workshop. Quite huge, to collect in each country so many nursing home staff for a 2-day physical intervention. Quite huge. Less is more, because in Denmark, where I come from, we've done two projects where we did the same, but we did two-hour workshop, not 2-day, two-hour workshop for the nursing home staff. And the results of the 2-hour working shop, which was about IPC and antibiotic, was that we saw a reduction, a 50% reduction in the use of antibiotic. And one of them was a randomized controlled trial, and there was no more residents who died or was hospitalized, so it was effective. 2 hours could do, and that is maybe my advice for JAMRAI. Maybe sometimes consider that less is more. All right? The second, pedestal. I talk in the context of long-term care facilities and nursing home staff. They don't know how important they are. You know, they are the frontliners, and they are the first one to see the changes at the residents. They know the resident best. So it's so important to tell them how important they are in relation to prevent infections, and also not to call the doctor for antibiotic. But often you hear them say, well, AMR, that's not my problem because I'm not the one who prescribes antibiotic. That's what they say, and then they lean back to our workshops and, well, it doesn't really. But then we tell them, you are so important because you can prevent the infections. And bear in mind that UTI is actually preventable. And it's the most common infection among elderly, but it is preventable. It's of course difficult when it's older people, but it's preventable. Yeah, thank you. That was the pedestal. Up with the end users on the pedestal. They are so important. Finally, the last, and that's a cliche. I know it's a cliche. It's time. But the project I've done, when I look at the project I've done, there is a clear correlation between the time, the amount of time that I have put in the project and the success. And I know, so my hope is that you will put time, heart and soul in the project, because that's sometimes worth it. I know we are all busy people and you compete with other projects and you have so many things to do, but time is really the most important thing also if you want to achieve results. And I heard the first day when I was here, I heard several times that we have budget. So you have budget, so I also think you should have time. Thank you.
Thank you very much. Thank you very much. The floor to Pilar for her intervention. Yes.
Thank you. Thank you very much. From the point of view of primary care professionals, and particularly family doctors, we need to ensure sustainability along the time to have impactful health outcomes. And we need to encourage the work of JAMRAI in 3 lines to continue to translate UE-level antimicrobial stewardship policies into realistic and implementable actions in primary care. They need to get involved into the fabric of multidisciplinary education, both undergraduate and postgraduate health professionals, to optimize awareness on infection prevention and control and antimicrobial stewardships. We need to meet primary care teams where they actually work in the digital clinical workflow. My advice is threefold. 1, information overload to avoid it. Move away from long reports, as Camelia mentioned. Instead, use push-up or brief clinical alerts integrated into electronic health records where we make decisions. 2nd, a cascade model. Use the national member organizations of primary care and family doctors as the World Organization of Family Doctors and their member associations, because we trust family doctors, and with programs as JAMRAI peer-to-peer program or the IPC Nurse Corner for primary care teams, the adoption rate will significantly increase, and then this model top-down will expand in European area, and introduce, as you are doing, new training tools to sense-making the way we are implementing IPC and AMRs. Gamification and visuals as the art project or memes strategy to make visible in the waiting room, in a staff lounge, in primary care facilities in Europe. Communication is also very important, performing it multidisciplinary, message for the doctor, for the nurse, for the pharmacist, reinforcing that we are a single unit of a stewardship, and also involving patients and civil society. I envision an impact that moves from defensive medicine we are sometimes practicing due to time constraints to confident stewardships. For the professionally represent JAMRAI 2 activities will provide a kind of safety net we currently need by accessing to peer-to-peer mentorship, behavioral science toolkit you are providing, family doctors and nurses will be psychological support when they choose to prescribe or not to prescribe antibiotic in daily basis. So that means add support or address clinical uncertainty in time of constraints through better access to rapid diagnosis tests and clear protocols for conditions, non-complicated infectious diseases, as well as reducing the environmental impact, and finally empower patients because unified European-wide communication will have already made citizens aware of antibiotic safe use before they even enter our consultation room. So I think this panel has shown the antimicrobial stewardship is a team sport, from the hospital alliance to the primary care facility to the suppliers. We are all part of the same team with the aim to improve people and planet health. And when we protect the effectiveness of an antibiotic, we are protecting one health for the future. And that's what family doctors are transmitting in every daily consultation as much as possible. Thank you.
Thank you very much. It's now finished our time. The timer is really judging us in a very serious way. So I'm very, very happy, and I would like to thank all the panelists and also you for the attention. I think that there were a lot of inspiration, suggestions, something to reflect also in the future. I think that for JAMRAI there is a very huge work to do, and I try to summarize from a I'm very happy for the practical vision, for the end users vision. I think that inviting here end user panelists is successful, is really a good idea, because they inspire for asking simple communication, pragmatic tools, not so many guidelines and papers, but something practical. And I would like also, finally, to thank Diamantis, because give me the chance to close this session with the inspiration vision of synergy. And this is a big value, especially for Europe in this moment. I think that synergy and cooperation is our strength. So thank you very much for reminding us this very important framework in which to work together. And I think that this is an example of synergy and cooperation that is productive. So thank you very much for the attention to everybody.